No, read what I wrote, I'm a bestseller. Yeah, reach for my goals, hit it dead center. Hit it dead center. Bullseye, hit it the most, is no misses. Something like fish in a barrel, it's no different. Blindfold on me, I still got the most vision. Trendsetter total.
So this time we are going to conduct in Kolkata at first week of June 2026. So venue and other details will be informed to you later. And at present, we are having a huge list of world leaders in dermatology for our show. So they'll be coming here and giving great lectures. So I'm very happy to see you all having interest in dermatology. And to improve your knowledge, we have been collaborating with the Drools for having a webinar series this year. So this particular seminar is mainly focused on hypothyroidism. See, as you all know, in our practice, we have got plenty of cases of hypothyroidism. But even then, we are having more number of cases. Sometimes we will miss or sometimes we will misinterpret, because you know very well, this hypothyroidism, whenever you go for a checkup, blood checkup, so if it is going to be lower total T4, immediately we cannot jump into a conclusion it is having a hypothyroidism. Prior history is so important. So the history, in that history, if it is going to have more number of exposure to the steroid or antifungal, like that we have got a list of drugs which can interact and which will give a lower value of thyroid. So it is very, very important to see everything, every aspect of hypothyroidism. That's why we wanted to focus more on it. And we want to have it from our expert, Dr. Lakshmi. You know, she is a professor in Hyderabad Veterinary College. So she is going to give idea about it. So I welcome all of you once again. And I request our Drools team to introduce her for this before going for lecture by her. Thank you.
Thank you, Dr. B. Nagarajan, for the welcome address. So before we start, I would like to request everyone to please fill out the form in the comments box to receive your certificates. So there is a link I have put in the comments box. So everybody, please fill out the form to receive your certificates. So now it's time to introduce our esteemed speaker, Dr. K. Lakshmi. Dr. K. Lakshmi is an associate professor of veterinary medicine with 17 plus years of experience in teaching, research, and extension. Her expertise lies in canine internal medicine, especially hepatobiliary disorders. She's published over 65 research articles and guided several postgraduate students with notable work in diagnostic and therapeutic studies in dogs. So we now hand it over to Dr. K. Lakshmi for her expert insights. Over to Dr. K. Lakshmi, please.
Good evening, everyone. Myself, Dr. K. Lakshmi. Presently, I'm working as Professor Veterinary Medicine, College of Veterinary Science, Rajendra Nagar. So today's my topic for the webinar is an insight to the diagnosis and management of hypothyroidism in dogs. Is my screen visible?
Yeah, make it full screen, madam.
Yes, it is visible.
Okay.
You have to make it full screen.
Yes, sir. Is it okay, sir?
Yes.
Yeah. So, as we all know, the canine endocrine system, so it consists of ductless glands which produce hormones, and these hormones they pass into the bloodstream for general circulation to excite or to inhibit certain activity of other organs or tissues. So among these glands, the thyroid gland is one of the largest endocrine gland which secretes the major hormones, mostly the thyroxine, that is the T4, and triiodothyroxine, that is the T3. So this hypothyroidism in dogs is the result of a decreased production of the T4 as well T3 by the thyroid gland. So this particular hypothyroidism we generally come across commonly in case of dogs and to an extremely in case of cats. So looking into the anatomical structure of the thyroid gland, so thyroid gland is said to be one of the largest endocrine gland which secrete major hormones, and it is a vascular globe structure which is located in the mid-neck region near the larynx. So this thyroid gland, as in the photograph you can see, it is made up of two separate lobes, that is the right lobe and the left lobe, and which is connected by a narrow band of the thyroid tissue called as isthmus. And histological section of the thyroid gland, it includes the lobes, that is the thyroid gland has the lobes which has the hollow spherical structures called follicles, and which this follicle is said to be the functional unit of the thyroid gland. So between the follicles, you can see there are certain parafollicular cells or the C cells. So these C cells, they secrete calcitonin, and each follicle is said to be filled with a thick substance called as colloid. So the major constituent of the colloid is the large glycoprotein, which is called as thyroglobulin. And you can see that the follicles, you have different types. One is called the resting follicles. So these resting follicles are larger in size, which has numerous vacuoles. And there are active follicles. These are smaller in size. So coming to the physiology and the metabolism. So whatever the hormones which are being produced, that is the thyroid hormones. So these are, we generally call them as iodine containing amino acids, which are being synthesized in thyroid gland. And these are being circulating as T4 and T3. So only all circulating T4, among which 20% of T3 is derived from the thyroid gland, and majority of the T3 is derived from some enzymatic reactions, which is called as extra thyroidal enzymatic reaction by deionization of the T4. And more than 99% of T4 in the blood and T3, these are bound to the plasma proteins, and these are more highly bound than T3. So coming to the thyroid hormone production. So as we discussed in the anatomical structure, the thyroid follicle. So these thyroid follicle, that is the thyroglobulin, this is being released into the colloid and by means of exocytosis. So wherein the iodine uptake generally occurs by the follicular cells from the blood, and then it is being transferred to the colloid. And then the iodine gets attached to the thyrosin on the thyroglobulin in the colloid, wherein one molecule of iodine or two molecules of the iodine, they gets attached to this structure in the colloid, and wherein the coupling process occurs between the iodinated tyrosine molecule to form T4, that is diiodotyrosine, that is T4, or monoiodotyrosine, that is T3. So the secretion of these T4 and T3 occurs through endocytosis, and coupling of T3 and T4 occurs, and these gets diffused out of the follicular cell to reach the general blood circulation. So this is how the thyroid hormone produced, and then it is being from the follicle it is being diffused out into the general blood circulation. So coming to the physiological aspects, the same thing what we have discussed now. So the iodinization occurs wherein the T3 and T4 through this exocytosis, and it gets diffused into the follicular cells. And then the most important thing when we look into, there are certain binding proteins called thyroid binding proteins. So these binding proteins generally help to bind the T3 and T4 levels, among which the most important is the thyroid hormone binding globulin, that is TBG. So most of the T4 is being bound to the TBG, and other thyroid binding proteins include transthyretin, albumin, as well as apolipoproteins. So these are the thyroid binding proteins. So when we look into the T4, so mostly 80% is being bound to the T4 binding globulin, whereas 10 to 15% pre-albumin and 5% to the albumin. And when it comes to T3, 70% is bound to the thyroxine binding protein and rest 30% to the albumin. And then free T4, so 0.04% is usually available, which is biologically active, and free T3, 0.4%, which is biologically active. And 99% of T4 and T3, these are generally bound to the serum proteins. And we also have thyroxine binding globulin, thyroxine binding albumin, thyroxine binding pre-albumin, and very to little amount is being unbound to the protein levels. So these TBG, so these binds the thyroid hormones, and these are synthesized in the liver. And thyroglobulin, this helps in the synthesis of T4 and T3, which is present in the colloid of the thyroid follicle. So only a few thyroid hormones which are unbound, so they enter the cells to produce what we call the biological effect. And there is also a negative feedback mechanism on the pituitary and the hypothalamus during the secretion of these hormones. When compared to T4, so the T3 has more affinity or more rapid onset of action, and they enter into the cell more rapidly as compared to T4. And these hormone receptor complex further binds to the DNA, and hormone synthesis occurs, and these are regulated mostly by the TSH, that is pituitary thyrotropin. And during metabolism of these thyroid hormones, so this occurs by a process called progressive deiodinization. So there is outer ring deiodinization and inner ring deiodinization. So outer ring deiodinization of T4, it produces T3, whereas inner ring deiodinization, it results in the formation of reverse T3, that is RT3. And this is being regulated by certain enzymes called deiodinase enzymes. And here the most important regulatory step is the thyroxine and T3. These are concentrated and then secreted in the bile. Coming to the various effects of the thyroid hormones on different organs. So one is the most important physiological effect is increase in the basal metabolic rate. And it has an effect on the heart, so which is nothing but the positive inotropic as well as chronotropic effects on the heart. And there is oxygen consumption of most of the tissues. And this thyroid hormones, it helps in the stimulation of erythropoiesis and regulate the cholesterol synthesis. The hormones also show the catabolic effects of the muscle as well adipose tissue, and there is the growth and development of neurologic as well as the skeletal system. When coming to the epidemiology of canine hypothyroidism, so certain studies, they say that the prevalence of canine hypothyroidism is usually ranging from 0.2% onwards. And the mean age of the animals which are being affected with this hypothyroidism is mostly the 7 years, and it may range starting from 6 months to 15 years. And coming to breed-wise prevalence, mostly the golden retrievers and Doberman pinschers, they are said to be more predisposed for canine hypothyroidism. And gender-wise prevalence indicate that neutered males and females are more predisposed, are mostly affected with this type of endocrine disorder. The etiology or the causes of the hypothyroidism includes the inflammation or shrinkage of the thyroid gland. So where the thyroid gland undergoes progressive destruction, which leads to reduced thyroid function levels. And whenever the thyroid function levels is reduced, you can find insufficient levels or decreased levels of thyroid hormones, that is T3 and T4. And mostly the middle-aged to older dogs are commonly seen, as we have discussed, and medium to large breed dogs. And this hypothyroidism we can classify into different forms. It can be primary hypothyroidism, secondary. So we'll see in the next slides. So coming to the primary hypothyroidism, it is nothing but the dysfunction of the thyroid gland. And this is said to be the most commonest form of the canine hypothyroidism among the adult dogs. So the hypothyroidism, this is more common, and this is caused due to lymphocytic thyroiditis, or it can be due to idiopathic thyroid atrophy. And the secondary hypothyroidism, so it is due to the deficiency of TSH, maybe due to certain conditions. It can be congenital conditions, or it can be due to pituitary gland destruction. So which may be probably because of certain tumors, or it can be due to trauma, or it can be due to autoimmune conditions like autoimmune hypophysitis, etc. Then there is another condition called tertiary hypothyroidism. So this is due to the deficiency of TRH, that is thyrotropin releasing hormone, which may be due to pituitary adenoma, and it can be a rare condition which we come across. The pathogenesis of the hypothyroidism, when we look into, so mostly it is due to the dysfunction of the thyroid gland and any part of the hypothalamic pituitary thyroid axis, because this hypothalamic pituitary thyroid axis, it plays an important role in the regulation of the thyroid hormones. Whenever there is dysfunction in this axis, it may result in canine hypothyroidism. And because of lymphocytic thyroiditis and idiopathic thyroid atrophy, there may be chance of the dysfunction in this axis. And sometimes we can also see that this condition may be multifocal, and you can also see there may be infiltration by certain cells. So that is diffuse infiltration of either lymphocytes, then plasma cells and macrophages. And the follicles, whatever which are present in the thyroid gland, so they appear to be smaller in size, and within the colloid, that is vacuolated colloid, we can see different type of cells like lymphocytes, macrophages, then degenerative follicular cells can also be seen. So this is what is going to happen. So the thyroid concentrations, as we have discussed, the hormone concentrations, it depends upon the axis, which we call it as hypothalamus pituitary thyroid axis. So this create a negative feedback loop. So from the hypothalamus, the thyrotropic releasing hormone, which is secreted, this has control, or it modulates the release of TSH from the pituitary gland. So once the TSH is released from the pituitary gland, it acts on the thyroid glands to release the thyroid hormones. So this process continues, and the increased thyroid hormones, on the other hand, they decrease the TRH synthesis and section, and this creates a negative feedback loop which inhibit the hypothalamus to inhibit the TRH. So this is what is going to happen in case of thyroid hormone production. And when we look into the histologic section of the thyroid gland, we can well appreciate the lymphocytic thyroiditis, where the lymphocytes has been accumulated in the thyroid gland, and there is loss of follicles. So because of the lymphocytes, the follicular size has been decreased, and these follicles, they contain certain colloid substances with the vacuoles and cellular debris. So this is HE stain image, where we can clearly see accumulation of the lymphocytes. And sometimes these seems to be an immune mediated, the canine thyroiditis, and there are certain antibodies which we call it as anti-thyroglobulin antibodies, so which are present in case of dogs affected with the hypothyroidism. And these antibodies, they usually seen as secondary conditions due to certain follicular damage or infiltrating T cells, or it can be directly involved in the thyroiditis, but this mechanism is not clear. And this is heritable in certain breeds, most probably in case of beagles. There is idiopathic follicular atrophy where the cause is unknown and the follicles gets atrophied, wherein the thyroid parenchyma will be lost and it will be replaced by the adipose connective tissue. So where the degeneration of these follicular cells occurs, and you can also see exfoliation of cells, and these all changes we can observe in case of colloid. And because of absence of fibrosis or inflammation, so this follicular atrophy is a kind of syndrome, and it may be a result due to thyroiditis, that is the inflammation of the thyroid gland. And this to some extent we can say hypothyroidism is also caused due to neoplasia, that is thyroid gland neoplasia, so mostly the metastatic neoplasia. So these dogs which are having metastatic neoplasia, so they have normal thyroid levels until the gland, that is the 75% of the thyroid gland has been destroyed. So after that only you can see the clinical signs which are evidenced. And this lymphocytic thyroiditis, this is said to be a risk factor for the neoplasia, that is metastatic neoplasia of the thyroid gland. Sometimes we can also encounter reversible primary hypothyroidism, so with the dogs which are given with the high doses of potentiated sulfonamides. Coming to secondary hypothyroidism, so the causes include pituitary malformations and pituitary neoplasia. So where you find histological changes like follicular epithelial cells flattening and distension of the thyroid follicles with the colloid. In tertiary hypothyroidism, there is deficiency of the thyrotropin releasing hormone. And the most important condition which we generally come across is cretinism, which is nothing but congenital hypothyroidism. So the causes may be, it can be due to deficiency of iodine, or it can be dysgenesis of the thyroid gland, or dysharmogenesis of the thyroid gland. And this congenital hypothyroidism or cretinism, along with the goiter, is due to thyroid peroxidase deficiency, and this seems to be an autosomal recessive trait. And this is the secondary congenital hypothyroidism is also encountered, but it is apparently isolated, maybe due to TSH or deficiency of the TRH. Coming to the clinical signs, so till now we have seen the anatomical structure, then the histological features, then physiology, epidemiology, and then pathogenesis. And as clinicians, we generally come across with the dogs or pets with different clinical signs, may be confused with other conditions. So these clinical signs need to be identified, and this along with other tests would yield at the proper diagnosis. So the thyroid hormone, as we all know, it has different functions and they have different effects on different organs. So this is said to be one important condition as a differential diagnosis in case of different disease problems. So clinical signs, when we look into, so they are commonly misdiagnosed, and the common clinical signs which we generally see include decreased metabolic rate, like lethargy. So dog seems to be lethargic, dullness, weight gain, then unwillingness to exercise, that is exercise intolerance and cold intolerance. So these common clinical signs we come across. Then these decreased metabolic rate, mental dullness, cold intolerance, exercise intolerance, weight gain. So these are the metabolic features which we generally see in canine hypothyroidism. So we can also see certain clinical signs like obesity, the sudden increase in the weight gain, mixed edema, and lethargic appearance. So mostly obesity is seen in case of 40% of the hypothyroid dogs. So apart from this metabolic changes, we also come across dermatological changes in most of the 60 to 80% of the hypothyroid dogs. So these dermatological changes include the dryness of the skin, scaliness, then changes in the hair coat, that is thinning of the hair coat, then change in the color, alopecia, seborrhea, and when it is superimposed with the other bacteria, it can also lead to superficial pyoderma. Then hyperkeratosis, hyperpigmentation, comedone formation, hypertrichosis. Then we also find otitis with cerumen, then poor wound healing, increased bruising, and mixed edema. So these are certain photographs which we come across with dogs suffering with hypothyroidism. So where we find alopecia with lichenification, the rat tail appearance, which is very specific for canine hypothyroidism, then thickening of the paw region, then excessive scaling, thinning of the hair, truncal alopecia, then hyperpigmentation is also one of the commonly seen, which may be misdiagnosed, then tragic facial expression. So alopecia in case of a hypothyroid dog is usually, when we see, it is bilaterally symmetric. And this alopecia is commonly noticed at ventral thorax, lateral tongue, and then at the tail region. So here the head and extremities, the hair may be brittle and they may be thin. And we may also see the coarse appearance, or we can also say puppy-like hair coat. So this is very specific for hypothyroid dog, and fading of coat color. And once the hair regrowth, that is the failure of the hair regrowth, is also one of the common dermatological findings we can notice. As I discussed, so there is a chance of predisposing to the bacterial infections, and which may end up with folliculitis, or it may end up in pyoderma or furunculosis. And sometimes if it is affected with fungal, you can also see malassezia infections, and demodicosis are also associated with hypothyroidism. So you can find the associated conditions along with the hypothyroidism. And mixed edema, so though it is a rare condition where you find non-pitting thickening of the skin, especially the eyelids, cheeks, and forehead, it is due to the hyaluronic acid deposition under the dermis. So it is one of the rare condition, and the complication of mixed edema is cutaneous mucinous vesiculation. Then we also come across with reproductive abnormalities, like in females, we can see prolonged estrus, interestrus interval, then silent heat, silent estrus, then failure to cycle or failure to conceive, spontaneous abortion, low birth weights, then uterine inertia. Then if they are born, they are weak, or stillborn puppies can be seen. And the bitches, that is the female dogs, they have low fertility rate, and they may have higher chances of mortality compared to the normal thyroid female dogs. And in case of males, we can see there is low libido, testicular atrophy, and the sperm count is very low, and azoospermia is generally seen, and the size of the testicles will be decreased, along with sterility, and then orchitis are commonly reported reproductive abnormalities. The nervous manifestations. So here both the peripheral as well as the central nervous systems are being affected, where the most commonly we can observe diffuse peripheral neuropathy. And along with this, you may find exercise intolerance, weakness, ataxia, quadriparesis or paralysis, and there may be certain deficits in conscious proprioception and decreased spinal reflexes. And you can also find unilateral lameness, which is one of the manifestation of this generalized neuromyopathy. And you can see the hypothyroid dogs with the head tilt. And this is because of the peripheral and or diffuse peripheral neuropathy. Then there may be the cranial nerves, mostly the facial, trigeminal, and vestibulocochlear. So these cranial nerves may be affected, and we can see the dysfunction of these cranial nerves. And these neurological signs, what we have discussed till now, so they may be controlled or they may be treated with the supplementation of the T4. So here we can also find abnormal brainstem auditory evoked responses. And when we perform EEG, that is electroencephalography, you may also find abnormalities, and there is abnormalities in the appendicular muscles also. Then cerebral dysfunction may be seen. So this may be due to different conditions, and most probably this may cause the secondary hypothyroidism. And this cerebral dysfunction may be due to either myxedema or coma or atherosclerosis or presence of any tumor of the pituitary gland. So all these may predispose to the secondary hypothyroidism. And there is a condition called myxedema coma. So where the dog, that is the hypothyroid dog, enters into profound mental dullness or stupor. And then we also find non-pitting edema along with cold extremities like hypothermia, bradycardia, weakness, and inappetence. So the presence of deposition of these certain substances like glycosaminoglycans, so this is responsible for the skin non-pitting edema, particularly in case of face and jowl region. And then we also find other neurological manifestations like seizures, disorientation, circling because of hyperlipidemia or cerebral atherosclerosis. And we also find behavior abnormalities, mostly the dysfunction of the cognitive system, and then aggression, myxedema, coma, and atherosclerosis. Then at times there is paralysis of the larynx, and then megaesophagus, myasthenia gravis, and muscle weakness and megaesophagus. So these are some of the clinical signs we can see. And the most important is because it has a effect, the thyroid hormones, they have the effect on the heart. You can see the cardiovascular system abnormalities also. So where the mostly it is represented by sinus bradycardia, then low QRS complexes, as we can see in the ECG, inverted T waves, weak apex beat, and left ventricular pump function. So because of this, there is a chances of dilated cardiomyopathy and hypothyroidism. So DCM and hypothyroidism, you can see as the secondary complications. Then along with the DCM, that is dilated cardiomyopathy, at times certain pericardial diseases are also been associated. Then aortic thromboembolism and pericardial effusion, so which is a cholesterol-based pericardial effusion. Then ocular abnormalities. So in the ocular abnormalities, mostly the corneal ulcers are commonly seen in the photograph we can observe. Then corneal lipidosis, the first photograph, uveitis, lipid effusion into the aqueous humor. So these we may misinterpret or misdiagnose, but these are also commonly seen ocular abnormalities. Then we also find glaucoma, and this glaucoma is secondary in nature, along with retinal detachment and KCS, that is keratoconjunctivitis sicca. Then congenital hypothyroidism or cretinism, the signs which we come across is mental retardation and stunted growth. So compared to the other healthy animals, that is euthyroid animals, it has stunted growth, which is specifically due to epiphyseal dysgenesis and also due to delayed skeletal maturation. The affected puppies seems to be normal at birth, but when we compare with the litter mates, they seem to have stunted growth, and as we discussed, epiphyseal dysgenesis, etc. They have broad heads, short, thick necks, short limbs, macroglossia, hypothermia. Then they have delay in the dental eruption, ataxia, and also abdominal distension. So these are present due to the large goiters are also commonly seen in cretinism because of iodination defects. And these dermatological findings in congenital hypothyroidism, like alopecia. So these signs are similar to that of adult hypothyroid dogs. And then we also find abnormalities in the gait, then difficulty in eating the food, stenotic ear canals, and constipation. And there is a condition called vertebral physeal fracture, which is going to cause tetraparesis. So this is a photograph where we can appreciate, so these two are litter mates, 8 months old. So the one on the left is a healthy dog with euthyroid or normal thyroid function, whereas the one on the right hand side, you can see it has stunted growth, and this is being affected with congenital hypothyroidism or cretinism. Then there is certain conditions, that is the thyroidism, the canine hypothyroidism. They generally occur with other immune mediated disorders, so that we call it as polyendocrinopathies. So mostly the canine hypothyroidism is associated with hypoadrenocortism and even diabetes mellitus. So because this hypothyroidism, it may cause insulin resistance and also cause an increase in the serum fructosamine concentrations. Then coming to the diagnosis part, so which is more important in diagnosing the thyroid dogs. So in this diagnosis, the patient selection is more important. So we need to generally look about the appropriate patient selection. So where the complete history of the dog, along coupled with physical examination, clinical examination, and the minimum database has to be acquired. Then testing of healthy dogs prior to breeding. So we need to test for the thyroid levels before breeding. And at times, these obese dogs without any clinical signs, also you have to check, because there is a chance of the obese dogs suffering with hypothyroidism. Then thyroid hormone estimation. So in the diagnosis, estimation of thyroid hormones is one of the key feature or salient feature which has to be checked for. So where we generally estimate total T4, total T3, and free T4, and these are expressed in different units. So there are different assays for estimation of these thyroid hormones, and detection of serum antibodies are also important. So these antibodies are against the detection of T3 and T4. And these antibodies, they may cause variation in the results depending upon the assay used. So this is about various diagnostic tests, the sensitivity, specificity, and accuracy. So among all the tests, so total T4, pre-T4, TSH, among all the three, TSH and T4, so the dog is considered to be hypothyroidism only if the T4, that is the total T4 or free T4 was low and high TSH. So these are some of the values where we estimate when we compare with the healthy animal with the dogs suffering with hypothyroidism. That is the total T3, the total T4, and fasting or free T4. So when compared to healthy control, the total T3 values are being reduced, and similarly T4 values are also reduced, and FT4 values are also being reduced. Among all the thyroid hormones, estimation of total T4 is said to be an excellent screening test in diagnosis of hypothyroidism. So we call a dog euthyroid when the T4 concentrations are within the normal range. So these thyroid values, they may fluctuate depending upon the time of the blood collection. It depends upon the age, then breed, season, and the temperature. So all these may influence the T4 concentration levels. So decreased T4 be normal for an individual due to certain non-thyroid illness, or it may be secondary to drug administration. So in such cases, you cannot consider, or you should be very careful. Then you need to couple with other clinical signs and other parameters to arrive at proper diagnosis. Then free T4 concentration. So here the protein bound hormone, it usually acts as reservoirs to maintain the concentrations. So here the free hormone concentrations, these are less affected because they bind to the receptors, and it gives a more accurate value of the thyroid function. So the standard method to estimate the FT4 is called equilibrium dialysis, ED, and the single stage solid phase, that is analog immunoassays. So these are said to be the standard methods, and we also have certain other tests like commercial free T4 assay also is used, and this is said to be more accurate than analog methods, and they are also more sensitive and also more specific in the measurement of T4. The equilibrium dialysis assays, these are not influenced by any of the antibodies, whereas other tests, these are influenced by these anti-T4 antibodies. Then total T3 concentration. So when compared to total T4, so this is less accurate method for distinguishing the dog with a normal thyroid level. And then because of these antibodies, the results what you get may be spurious. Then estimation of reverse T3 and free T3 concentrations. So here the main mechanism or background here is decreased activity of 5-deiodinase enzyme, and because of which you can find these concentrations, this has not yet demonstrated. And then the most important apart from T4 estimation is TSH. So this is having a good sensitivity and specificity in diagnosing the condition. And the hypothyroid dogs may have sometimes normal TSH levels, and it may also in along with the low T4, you should come to a conclusion, that is elevated levels of TSH along with low levels of T4 should be the confirmatory diagnosis for the hypothyroidism. So any time whenever you want to get the dog diagnosed, so the measurement of these values, that is the total T4 and the measurement of TSH, would yield at proper diagnosis of hypothyroidism. Then there are certain drugs. So these drugs, they show effect on these thyroid hormone concentration. So like for example, when we look into the glucocorticoids, so oral administration of glucocorticoids at immunosuppressive doses. So these have shown a rapid decrease in the T4, T3 and free T4 levels, but a little change in the serum TSH because it influences the peripheral metabolism of the thyroid hormones, and it inhibits TSH secretion. Then certain sulfonamides, these sulfonamides, they generally they hamper or they block the iodination of the thyroglobulin, and it may also cause clinical hypothyroidism. And certain drugs like sulfa-trimethoprim, so they also caused clinical hypothyroidism at a dose of 24 mg per kg for every 12 hours. So these are some studies which show the effect on the thyroid hormones, and at that time you should not confirm the case as hypothyroidism. And similarly, trimethoprim with sulfamethoxazole at the dose of 30 milligrams per kg, which was given orally. And administration of phenobarbital also caused a decrease in the total T4 and free T4 concentrations. And other drugs which also show effect on thyroid hormone are heparin, NSAIDs, that is non-steroidal anti-inflammatory drugs, then propranolol, amiodarone, and also certain radio contrast agents and iodine. And effect of systemic illness on thyroid hormone concentrations. So in case of non-thyroid conditions or non-thyroid illness, the thyroid hormone concentrations also decreases. For example, in case of certain release of certain cytokines like interleukin 1 or interleukin 2 or interferon gamma or TNF alpha, so all these may decrease the T4, and because of the change in the hormone binding to the serum carrier proteins. And certain medical conditions which decrease total T4 concentrations includes hyperadrenocortism, as we have discussed earlier, because it has some association or secondary complications we can come across. Then diabetic ketoacidosis, hypoadrenocortism, renal failure, and hepatic disease. Then nervous conditions like peripheral neuropathy, megaesophagus, heart failure, then any critical conditions, surgery or anesthesia. Then coming to assessment of these, it can be assessed through different way. So among which the most commonly used is radioimmunoassay method. So here it is one of the competitive assay method to estimate the values of total T4, free T4, and total T3. So here we generally use these radioimmuno assay method where associated calibrators are being incubated with labeled T4 and T3, and in case of antibody coated tubes. And then in case of or after incubation, you can see that the liquid content is aspirated, and the radioactivity which was bound, so it has to be measured by using a gamma count. And then the results will be interpreted in the form of a standard curve, and then with this we can know the values of the thyroid hormones. And then TSH stimulation test, so this we generally call it as one of the most important test which determines the thyroid function. So where we give 50 to 75 microgram per dog or 100 microgram for dogs of more than 20 kg, and then we generally collect the samples just before giving the TSH, and then after 6 hours after administration of TSH. So whenever if there is any changes in these levels, for example, if the total T4 concentration is above 1.5 times the base level, then you can say that the dogs have normal thyroid function, or we can say euthyroid dogs. Whereas the hypothyroid dogs will show minimal stimulation. So as discussed, if it is less than 1.5 milligram per deciliter. The TRH response test. So this is to evaluate the thyroid function in place of TSH response test. So here we give TRH at the rate of 0.01 to 0.1 milligram per kg. Then we collect the blood just before administration of TRH, then 30 minutes and 4 hours after TRH administration. So lower doses, you can see there is an increase in total T4 concentration, and sometimes the higher doses may result in certain side effects like salivation, vomition, urination, defecation, etc. And now the upcoming advanced diagnostic tool is thyroid scintigraphy. So where we generally measure, that is the quantitative measure of the thyroid uptake by after administration of the radioactive and radioisotope pertechnetate. So this has to be given, and then you can just check how much the thyroid uptake is being assessed. So this differentiate the hypothyroid dogs from the dogs with suffering with non-thyroidal illness. So appearance of the normal thyroid scans. So whenever when we give these radioactive substances, the symmetrical uptake by the paired thyroid lobes you can generally observe. And if the uptake is homogeneous And if the margins are smooth, then you can say that the condition, or in case of a euthyroid dog. So normally in case of normal thyroid function, so it can take, that is the dog, the median uptake of this substances is around 0.62%. Whereas in case of hypothyroid dogs, you can see that the median uptake is only 0.16%. That is, the value has been decreased. And this scintigraphy plays an important role to identify any underlying cause of any congenital hypothyroidism. And this scintigraphy also help in identifying central hypothyroidism. And administration of TSH for 3 days, it will not alter any thyroid image, but does result in case of thyroid uptake. And this uptake of radioactive iodine and perchlorate discharge, it may be also useful in identifying or in diagnosing of congenital hypothyroidism. So here the radioisotope pertechnetate can be given, and this is the procedure what we generally follow, where we use gamma camera before the radioisotope is being injected into the dogs. Then we generally calculate the radioactivity of the empty syringe and radioactivity of the previous which we have given through the cephalic vein, and the difference gives you the actual amount which is injected into the cephalic vein. And before this, we need to pre-medicate the dogs with induction with xylazine. And scintigraphy is usually performed 20 minutes after the injection of these radioactive substances. So this is, the dogs are placed under this gamma camera in dorsal recumbency, and then we have to take the images. And the other important diagnostic non-invasive technique is thyroid ultrasound. So the dogs suspected for hypothyroidism are being scanned for the thyroid gland. And the thyroid gland, as we know that in case of hypothyroid dogs, the size is very small and it seems to be less echogenic. And we need to scan both the left and right lobes. And also you can calculate the thyroid volume, which is very specific for the diagnosis of hypothyroidism. So for this, we can use a linear probe of 10 megahertz, and this probe you need to place on the thyroid gland, especially lateral aspect of third to fifth ring below the larynx. So the normal thyroid gland seems to be hyperechoic, and it has the homogeneous parenchyma, and the capsule seems to be hyperechoic. So this is the normal thyroid gland structure. Whereas you need to take the transverse section images and longitudinal images to check for the echogenicity, size and shape of the thyroid gland. So these are some of the photographs we can see. So this is the thyroid ultrasound. In the first photograph you can see, so this is the right lobe of the thyroid gland, and this is the left lobe, and this is the trachea. So you can see the size, and also you can see that ill-delineated thyroid lobes are being present. And this is the right thyroid lobe, where you can see the capsule and you can see the structure. Then thyroid gland biopsy. So this is also one of the definitive diagnostic tests, but it has certain complications. And here the main findings what you see here is lymphocytic infiltration along with macrophages and plasma cells. And there is thyroid parenchyma is eventually destructive, and it is being replaced by the fibrous connective tissue. And coming to histopathology of the skin, that is dermatohistopathology. So this is not specifically diagnostic test, but because of the dermatological changes what we have seen. So there are certain histopathological changes what we generally come across is epidermal and follicular hyperplasia, then predominance of telogen follicles, sebaceous gland hyperplasia, mucinosis, and also bacterial folliculitis. So these are some of the images of histopathological section of the skin affected with hypothyroidism. In the first photograph, we can see hyperkeratosis. Then there is inflammation and infiltration of the neutrophils. Then in the third, we can see the inflammation of the hair follicle. So the most important is the treatment aspects in case of canine hypothyroidism. So whatever may be the underlying cause of hypothyroidism, so we generally use levothyroxine, and it has a half-life of 10 to 14 hours, and oral bioavailability is 10 to 15%. So administration with the food has shown to decrease the bioavailability. So there are certain general conditions which we have to look into before starting the treatment. So the diet which you give to the dog, it should have the reduced fat, because it may also see abnormalities in the serum lipid profile. Then lifelong treatment is necessary, and it has to be evaluated for every prior to the increasing or adjusting the dose. It has to be evaluated. Then response to the therapy. So once you start the treatment, so we have to see how the dog is responding for your treatment. That is for 7 days, within 7 days for nervous manifestations like neuropathy. Then 4 to 6 weeks for the abnormalities and general systemic signs, and 1 to 3 months for dermatological conditions. And excess dosage of these medication may also lead to a condition called thyrotoxicosis. So in a dog with thyrotoxicosis, there are certain manifestations which we can generally see is tachycardia, diarrhea, polyuria, polydipsia, polyphagia, pruritus, anxiousness, and also behavioral changes. So the drug of choice when we look into, so synthetic L-thyroxine, that is levothyroxine, at the rate of 0.02 mg per kg for every 12 hours. And the dose has to be, it has to be modified or adjusted depending upon the concentration of this T4. And sometimes synthetic T4 can also be given, but this is not recommended because there is a more chance of thyrotoxicosis T3 supplementation. And need to look into, because there are certain associated signs like congestive heart failure, renal disease, diabetes mellitus, seizures, and hypoadrenocortism. So based on the condition, along with the medication, so the underlying cause has to be determined and treated accordingly. And this treatment, whether the dog is being treated properly or not, that it has to be evaluated, and it should be confirmed after monitoring for 4 to 8 weeks once you start the treatment. And every time evaluate the T4 concentration, and it should be within the reference range prior to the administration of a dose. And if it is above the reference range, you have to adjust the dose. And it may result in sometimes over supplementation in case of few dogs. So based on the clinical response, therapeutic monitoring, and presence or absence of concurrent illness, the therapy has to be finalized. And when you find improvement in certain changes like improvement in activity, improvement in the weight loss, improvement in the dermatological disorders, so all these things has to be checked periodically. And as I said, the improvement in the normal hair coat, so it may take several months, and it may take several months for the dogs to come to its normal status. And sometimes you may find improvement in the myocardial function within 8 weeks, or it may also be up to 12 months. So neurological defects also may improve, but complete resolution may take up to 8 to 12 weeks of time. And sometimes these concurrent conditions like cardiomyopathy. So in these conditions, the thyroid hormone supplementation, it will increase the myocardial oxygen demand, and this finally result in cardiac decompensation. So this dose of the thyroid hormone at this condition, it has to be replaced to 25 to 50%, and then it can be based on the results of the monitoring and re-evaluation of the cardiac function. And hypoadrenocortism. So here we need to check for the glucocorticoid deficiency and replacement of the mineralocorticoid because of the increased BMR, that is basal metabolic rate, and the appropriate range along with this concurrent non-thyroid illness. So this has to be treated and check accordingly. And sometimes there is a chances of treatment failure where the incorrect diagnosis plays an important role in the treatment failure. For example, the secondary conditions like hyperadrenocortism, atopy, flea hypersensitivity. So all these conditions may have similar clinical signs, and it may be associated with decreased thyroid hormone concentration. So this we call it as sick euthyroid syndrome. So this we have to taken care and see that the dog is being diagnosed for the hypothyroidism. And sometimes there are certain other causes like insufficient absorption of T4 from GIT, and so this can also be substituted for T4. And the prognosis is excellent, we can say, because it doesn't take, or we can say it's good, because it doesn't move, or it doesn't cause much harm. And we can say the prognosis for return to normal function is good. But an exception is in case of certain advanced cases, the resolution of the clinical signs, especially in case of cretinism or congenital hypothyroidism, mostly depend at the age at which it is diagnosed and the age at which the treatment is being initiated. Thank you.
Thank you. Thank you, Dr. Lakshmi, for that enlightening and insightful session. So we from the Drools team now present our ongoing initiatives in veterinary education and share details of upcoming webinars. So these are few upcoming webinars scheduled for the coming months. So in August on 24th, we have a webinar on the mite infestation in pets. And lined up till December, we have lots of webinars in collaboration with IAVD. So all the participants, they can fill the links as and when we upload them or share them on the social media platforms. So it's time for an interactive Q&A. If you have any questions for Dr. Lakshmi or Dr. B. Nagarajan, please drop them in the chat box. Okay, so we have one question from Tushara. So, doctor is asking, is it advised to supplement thyroid hormone due to idiopathic causes? Like if total T4 is low due to corticosteroid supplementation, should we give thyroid supplementation?
Yeah, doctor, like as I mentioned earlier, if it is an idiopathic cause where the cause is unknown, and if because of the corticosteroid stimulation supplementation, if the value of the T4 values are being altered, so you kindly check for TSH and other clinical parameters. So based on that, you can plan whether to give the thyroid supplementation or not. Because as I said, certain drugs, so they have an alteration in the hormone levels, the thyroid, especially the T4 and T3 levels. So better to have other diagnostic modalities done and then decide.
All right, doctor. Thank you. So one more question is there from Mihal. Can topical steroids also lower T4 levels? Also, after how many days of stopping steroids, topical or oral, should we check for thyroid function blood test?
Yeah, so topical steroids, probably the absorption, it varies upon the absorption. Suppose if you're giving topical as well as oral steroids, and better you give a gap of few days, probably around 3 to 4 weeks, and then go for a blood test.
All right.
If you're finding any other associated signs along with that, then you can plan whether it is a case of hypothyroidism or not.
All right. So one more question is there. If there is concurrent cardiomyopathy, what should be the approach?
Yeah, if it is the dilated cardiomyopathy associated with associated with hypothyroidism, we need to check what kind of condition it is. If it is a case of DCM, if it is a case of dilated cardiomyopathy, then we need to plan the treatment accordingly by providing inodilator and all. So the condition has to be diagnosed through echocardiography. So which type of, or if it is a case of only DCM, or if it is a case of any valvular disease, so based on that, the treatment has to be given.
All right. So one more question is there. What are the alternative treatments along with levothyroxine and other drugs contraindications to be kept in mind?
Okay, so what are the other treatment is like we generally along with the levothyroxine based upon the associated signs. Suppose if it is related with other dermatological conditions, like we said, there is a chances of secondary demodicosis or malassezia, or the conditions has to be diagnosed, and if it is the based on the condition along with the levothyroxine we can give. And contraindications certain drugs like steroids because they may hamper the thyroid levels.
Okay, all right. So one more question from Sridhar. What is the percentage of hypothyroidism in skin infection in dogs?
Percentage, it depends upon the cases which are present at your area, probably. Mostly, I think it may be around 50 to 60%. Because a dog affected with hypothyroidism, the dermatological disorders, you may find around 60 to 70%.
All right. So, question from Dr. R.R. Dash. If we are treating with levothyroxine, what are the side effects we should be careful about and how should we address them?
If you are treating the thyroid dog with the levothyroxine, we need to adjust the dose depending upon the body weight and all. Why? Because there is a chance of thyrotoxicosis. So, where in case of thyrotoxicosis, you find other associated signs. So, the dosage based on the body weight has to be monitored regularly. That's the
All right.
main thing we need to look into.
One question again. What time of the day is good for administration of levothyroxine medications?
So, morning is ideal.
Okay. So how to go for estimation of TPO, anti-TPO and TG antibiotics?
Antibodies probably. So, we have different
Yeah.
tests like ELISA based radio immunoassays. We have different tests available, so that can be used for diagnosing these condition.
Okay. So one more question is there. Is it ideal to give L-throxine before food?
Yeah, it's ideal.
Okay. So one question from Chandrakant. He's asking, ma'am, do you give any thyroid hormone reference range in your institute or clinic setup?
The slide I think we have presented, because in healthy control and similarly in case of hypothyroid, so we have the range which we follow from the textbook itself. We generally don't have a specific range, so we generally follow the textbook, the values for T3
Okay.
and T4 values.
Yeah. So one more question is there. Can we use human thyroid panels for evaluation of hypothyroidism in dogs?
Can you repeat?
So the question is, the Dr. Pranav is asking, can we use human thyroid panels for evaluation of hypothyroidism in dogs?
Yeah, to some extent can.
Okay. Yeah. So there is one last question. Is Hashimoto's thyroiditis available in dogs? And do you have any thyroid hormone reference range? Again, the same question is repeating. So,
Regarding this, I don't have any idea, sir. This Hashimoto's thyroiditis. Uh,
okay. So we'll take this last question.
yeah,
So Sridhar is asking when to think for hypothyroidism in skin infection.
that's what. When suppose a certain skin changes like tactile appearance, then bilateral symmetrical alopecia. So such skin infections or such signs, dermatological signs, then you can think of it may be a cause of hypothyroidism.
Okay. All right. Thank you so much, doctor. So one more question is coming up. I will take this last question as well. So is human-based levothyroxine sodium can be given to dogs if set according to dose? If set according to those, they are available in capsule forms. Are they safe?
Can you repeat, ma'am?
Yeah, the question is human-based levothyroxine sodium can be given to dogs?
Yes, we
If
can do.
set according to dose, they are safe in capsule forms. Okay, so thank you, Dr. Lakshmi, for answering all
Yeah.
the questions very patiently.
Thank you. Thank you.
So, to conclude, now we have Dr. D. Sumati, Vice President of IAVD, to deliver the vote of thanks. Over to Dr. Sumati.
So it's a proud privilege to give vote of thanks to today's lecture. The topic covered extensively from the anatomy to physiology, then the practical insights into the hypothyroidism. Thank you, Professor Dr. Lakshmi, for your elaborate lecture on hypothyroidism. In this Sunday evening, participants who were very actively involved in listening to the talk by Dr. Lakshmi, I thank you all. I thank Professor Dr. Nagarajan for making this possible every month to hear on dermatology on behalf of the IAVD team. I also would like to thank the Drools team who had been doing this continuously, and there are 8 follow-up of lectures, and I would like the participants to meticulously follow these lectures so that they will benefit in the upcoming webinars. Thank you, one and all. Thank you.
Thank you, Dr.
Thank you, ma'am.
Sumati.
Thank you, ma'am.
So, before we wrap up, a gentle reminder to all the participants to fill out the form in the comments box to receive your certificates. And thank you all once again for joining us. We look forward to seeing you all in our future sessions as well.
You know, my friends and I, we talk about everything under the sun. So how can we leave out discussing something as important as our pets and their diets?
Always remember to check the back of the pack when it comes to buying food for your pets.
Make sure that you're feeding only real and clean ingredients.
It is 100% real chicken.
No byproducts
Or fillers.
All natural, all healthy ingredients.
It gives them the best of both, taste and nutrition.
Drools.
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 Drools. Feed real.
Fit clean.